Hello, my name is Gregory Kitchka. I'm from University of Washington Department of Radiology, and I'm going to be discussing CT and MR evaluation of right heart function and pulmonary hypertension. So pulmonary hypertension is defined by a pulmonary artery pressure that is greater to or equal than 25 millimeters of mercury. There are borderline cases which are defined as 21 to 24 millimeters of mercury. And this is not a rare disease, but certainly I wouldn't say that it is common. The best estimate for the prevalence of the disease comes from the adjusted death rate, which puts it at about 5 to 7 per 100,000 people in the population. It is responsible for approximately 1 in 1,000 hospitalizations. When patients with pulmonary hypertension first present to a physician, their symptoms can often be vague. Some of the patients will have dyspnea, a few less will have fatigue. Many of the patients will not have symptoms at all, and this is probably because the onset of pulmonary hypertension symptoms is often insidious, and so patients don't quite realize that their function is degrading. Patients may also present with a variety of historical elements that may increase your suspicion for pulmonary hypertension, and these are listed here below. In the evaluation of pulmonary hypertension, it starts off with a patient in which you are suspected that pulmonary hypertension is present. These patients will, the current practice is for the most part to receive an echocardiogram. If that echocardiogram has findings that are compatible with pulmonary hypertension and there is no left heart disease, then those patients would proceed to a right heart catheterization to establish the diagnosis. But if the echo has no findings that are compatible with pulmonary hypertension, but a high suspicion of pulmonary hypertension still exists, those patients will go to right heart cath. Now, this is a very simplified diagram of the true algorithm, but it illustrates that there are 2 points where patients receive either imaging or an invasive test to measure their pulmonary artery pressures. The thought is, wouldn't it be nice if you could somehow use MR or CT to get the same information that you get from echo and maybe a little extra information that's only available with right heart cath? It seems logical given that echo, CT, and MR are all cross-sectional modalities, and maybe there is something additional that we can get to get us a little closer to finding the true mean pulmonary artery pressure. There are other motivations for this. Right heart catheterization is the gold standard. It is a low-risk procedure, but it's not a procedure without risk. Complication rates include about 1% hospitalization and fatality at 0.06%. So there is a clinical need for a non-invasive method of measuring right heart pressures. So what can CT and MR do? There are basically 3 main questions that CT and MR can address. One is diagnosis. Is pulmonary hypertension present? And this hinges on what is your estimation of the pulmonary artery pressures using those modalities. Second is etiology. What is the cause? In other words, how should we treat this person? And then prognosis. Is the treatment working? So those are 3 things that we will try to answer with our imaging: diagnosis, etiology, and prognosis. Now, as I said, right heart cath is the gold standard. It's not done as the first test because it is not a zero-risk procedure. I like to think of right heart cath a lot like a tire gauge. It is the most direct way to measure what the pressure is in your tire. CT and MR, and echo for that matter, is a little bit more of an indirect measurement of checking the pressure in your tire, analogous to kicking it a few times to get a sense of what the true pressure is. This method is imperfect. It will never replace a direct measurement, but maybe there are ways we can learn to better kick the tires. So on CT, let's start talking about something you are all familiar with, and that is measuring the pulmonary artery diameter. We're all familiar with this cutoff of 2.9 centimeters. It involves measuring the main pulmonary artery near to the location where it passes by the aorta. A diameter greater than 2.9 centimeters confers an 87% sensitivity and 89% specificity for identifying people with a pulmonary artery pressure above 25 millimeters of mercury. But you want to use caution in patients with interstitial lung disease. Those patients can have very big pulmonary arteries, and it doesn't necessarily mean they have hypertension. Their pulmonary artery could be 4 centimeters and yet only have mild hypertension. Also, you have to be cautious in patients who are post-lung transplant. Many times those patients did have pulmonary hypertension, and after the lungs are transplanted, the hypertension may be gone, but their old pulmonary artery is still there, and it doesn't go down in size. To give you an example, some false positives that you can get using this method, this is a patient without pulmonary hypertension. Their pulmonary artery pressures were normal, but they had vasculitis, and it was thought that that was the cause of the patient's dilated pulmonary arteries. You can also have congenital pulmonary artery aneurysms that will occur in the main pulmonary artery where the patient on right heart cath has normal pressures. You have to be careful measuring the pulmonary artery, whether you have a gated or ungated exam. Those exams are not perfect. For example, if you look closely, you can see this type of ghosting artifact. It occurs because this image was captured during systole. So this diameter measurement would be in error because of that. This is an image taken without systolic blurring, and you can see that your pulmonary artery diameter, the best estimate that you have it on this axial image, would be normal. Volume stats can also affect diameter of the pulmonary artery. This is a patient with a 3.6 centimeter pulmonary artery. You can see they had peritoneal effusion. This patient had severe edema. This was an exam performed 2 days later, and you can see their pulmonary artery now is 2.6 centimeters after they have been diuresed. Right and left pulmonary arteries have upper limits of normal for their diameters. The right pulmonary artery greater than 24 is abnormal. Left pulmonary artery greater than 21 is abnormal. And this is particularly useful if those dimensions are flipped. In other words, if the left pulmonary artery is substantially larger than the right. And this is an extreme example of that. This is a patient with pulmonary valve stenosis, and you can see how large the left pulmonary artery is. It's because the stenotic jet is actually directed into the left pulmonary artery. People often talk about segmental pulmonary arteries, and when your segmental artery to adjacent airway ratio is greater than 1.1, what that does is it increases the performance of your main pulmonary artery measurement. So the sensitivity and specificity for using that threshold of 29 millimeters increases when you also see segmental artery to adjacent airway ratio greater than 1.1 in more than 3 lobes. Another imaging feature that we use is the ratio of the pulmonary artery and the aortic artery. If the pulmonary artery to aortic artery ratio is less than 1, that is 92% specific for mean pulmonary artery pressure greater than 20 millimeters of mercury. So let me just rephrase this. In other words, 92% of patients with a mean pulmonary artery of less than 20 millimeters of mercury will have a PA to AA ratio less than 1. The reason this is helpful is because as people age or as someone's weight increases, the aorta and pulmonary artery will both dilate, and that pulmonary artery may exceed a threshold of 2.9, but there's no pulmonary hypertension present. Let's talk about MR evidence of pulmonary hypertension. There are many metrics for pulmonary hypertension that are seen on MR. I will not be able to talk about all of them, and so I will focus on ones that I think are a combination of the easiest to perform given the current methods, the commonly accepted way that people are probably imaging their patients, and also have the best evidence behind them and are the most useful. So what I'd like to start with is ventricular mass index. The ventricular mass index is the mass of the right ventricle divided by the mass of the left ventricle. These images are generally acquired on bright blood cine images, so balanced, steady state, free precession images. When you segment the RV, you want to make sure that you include the septal trabeculations. You want to measure the volume on any single phase, although I find diastolic phase is, of course, the easiest, and you want to use the short axis plane. So here's an example of segmenting out the RV. Using the short axis plane is important because when you have differences in breath hold from one acquisition to the next, the heart can change position similar to what you're seeing here. And you can imagine that if you were acquiring 4-chamber view at the same location on the table, you would actually miss quite a bit of the right ventricle on that, and it would affect your volume measurement. So for the most part, it is better to use the short axis for that mass measurement. Now, the mean pulmonary artery pressure is predicted by the ventricular mass index, and that's what I'm showing here. Right? The correlation value was 0.81, and if you use a cutoff of 0.6 of the ventricular mass index, that confers an 84% sensitivity and a 71% specificity in this study that I'm referencing here. Now, people have pooled data from multiple studies that have looked at that, and the result from that is that if you use a ventricular mass index cutoff of 0.45, that you would have a sensitivity of 84% and a specificity of 82% with the confidence intervals that I indicated here. In this particular study, they pooled data from 5 research studies. So people who have looked at ventricular mass index have also looked at some other metrics. And the other one I would like to discuss is the interventricular septal angle. And you can see the correlation value comparison here. It is as good as the ventricular mass index in this study. RV, DV, EF, those were also investigated, but they were inferior predictors of predicting the mean pulmonary artery pressure. So the interventricular septal angle is calculated by drawing a point at the RV insertion site on both sides and then picking a midpoint within the septum. You want to choose the phase where the septum is undergoing its maximum deviation, which is end systole, and then you measure the angle here. That is the interventricular septal angle. Here we are comparing a patient with pulmonary hypertension to a patient without pulmonary hypertension, and there's that septal bounce everyone is familiar with. And that is what contributes to that change in the interventricular septal angle. The reason that you get flattening of the septum in pulmonary hypertension is because as you have hypertension in the right ventricle, systole becomes prolonged. Systole ends in the right ventricle after the left ventricle, and that difference just becomes wider with pulmonary hypertension. And that's where you get the appearance of that splitting of the second heart sound. So it is during the short period of time where the left ventricle is finished with systole, has begun to relax, but the RV is still contracting, and then therefore pushes the septum across toward the LV. You can appreciate that with these flow curves here. They show that the dotted line is the right ventricle. As the right ventricular diastolic pressure increases, there's this small crossover period with respect to the left ventricle where the right ventricle is still undergoing systole. But the left ventricle has fully relaxed, and that leads to the septal bounce. For interventricular septal angle, when the septum is flat, the systolic pulmonary artery pressure is around 67 millimeters of mercury. In other words, it is abnormally elevated. So in patients with pulmonary arterial hypertension, who then are treated with vasodilators, it's been shown that septal deviation will decrease. The sensitivity and specificity for identifying somebody with pulmonary hypertension is within the range described here. The best metric for predicting mean pulmonary artery pressure is a composite score of the interventricular septal angle and the ventricular mass. It's the interventricular septal angle times 0.23 plus the ventricular mass index times 16.3 minus 4.6 gives you your estimate of the mean pulmonary artery pressure. This was quite a large study. However, there's no pooled data that exists because other studies have not looked specifically at this metric. This shows you the correlation between mean pulmonary artery pressure determined at right heart cath, and that derived from the composite score. This study from 2013 actually determined the composite score on a derivation cohort and then actually validated it on a separate cohort. The area under the curve is 0.94, and if you use a cutoff of 32 millimeters, it is 87% sensitive and 90% specific for predicting patients with pulmonary hypertension. And that is 32 millimeters of mercury from the composite score gives you the sensitivity and specificity for a 25 millimeter mercury threshold on the right heart cath score. So now let's talk about etiology. One of the benefits to using CT and MR compared to echo is that you can uncover other diseases which could be causing pulmonary hypertension, and therefore increasing your confidence in the diagnosis and also saving a step in the patient's workup. These are the 5 types of pulmonary hypertension, and I have color-coded the diagnoses based on the modalities that can make those diagnoses. For example, LV dysfunction or mitral disease is best evaluated on MRI. But for example, aortic disease or congenital heart diseases you can see on both MR and CT. When it comes to classifications of pulmonary hypertension, there are 5 types. There are some of us who still think of pulmonary hypertension in terms of primary and secondary. Essentially, primary is type 1. These are also patients called with pulmonary arterial hypertension. When that term is used, it's another way of stating it is somebody with type 1 pulmonary hypertension. Patients with secondary pulmonary hypertension are these types 2 through 5. So you can see type 1 is our idiopathic type as well as some others, but those are the patients with pulmonary arterial hypertension, versus types 2 through 5 have some other type of disease, whether it be chronic PE, lung disease, some type of cardiac disease, some sort of left heart dysfunction. Type 1 accounts for approximately 10% of all pulmonary hypertension cases, and then within these remaining cases, 2 through 5, the most common is thought to be chronic PE. It does matter what is the etiology of the person's pulmonary hypertension, because there are different courses of treatment. This is a primary therapy. This term corresponds to this type of treatment. And then there is advanced therapy. Primary therapy should only be given to patients who are type 2 through 5. If you give primary therapy to type 1 patients, it is not beneficial. And giving advanced therapy to some patients in category 2 through 5 can actually be detrimental. So it is very important to establish a diagnosis establish an etiology, because it truly does guide treatment. Now, what can CT and MR tell us about prognosis and treatment response? People have looked at a variety of functional parameters, and some of which are derived, such as mean pulmonary artery pressure, in patients who have undergone therapy for in this case, it was actually patients with chronic PE. And they've shown that when the pulmonary hypertension is improved or resolved, you actually have remodeling of the heart and recovery of some of these functional parameters. Okay. So this was in a study with 72 patients pre and post therapy. Pulmonary artery area change is something that has been shown to indicate prognosis in patients. For example, if the blue is the pulmonary artery during diastole and the red is the pulmonary artery during systole, and this is the cross section, so you can see there's a substantial area change between these two, compared to this patient over here where the pulmonary artery does not change as much between diastole and systole. These patients are thought to have a stiffer vessel, and having a pulmonary artery change that is low, less than 16%, is associated with a worse prognosis. Okay. This is the survival curve for patients with pulmonary arterial hypertension, so type 1 patients who had a relative area change of greater than 16%. In other words, their pulmonary artery was not stiff. These are the patients with a relative area change of less than 16%, and you can see the difference in the survival curves. Now, there are other MR metrics for measuring pulmonary artery hypertension. I'm going to mention them briefly, but not talk about them in detail. I do want to mention them just so that you know they exist and you can investigate them further. One is tricuspid jet velocity. This is used extensively in echo. However, in MR, its utility is not as well established. There are metrics that involve looking at the flow curve for the main pulmonary artery. One of them is the acceleration time. How long does it take you to get to the peak of the velocity? Normal patients will have a longer acceleration time compared to patients with pulmonary hypertension. There's also the maximum change in flow, that is how steep this slope gets for as you go up the flow curve. There's also looking at the difference in flow as you go around the edge of the pulmonary artery or go toward the center. And these are basically different measurements of shear. There's also something called the Windkessel function, which measures how much flow goes into the pulmonary artery on one end and how much comes out downstream. So if a pulmonary artery is elastic, it will absorb the flow, so there'll be a delay. So when you have 10 milliliters enter here, you may only have 5 milliliters exit here. The 10 will eventually get all the way out, but it is delayed in coming out. So that's a measurement of the elasticity of the vessel. Another is the tricuspid annular plane systolic excursion measurement. This is a measurement that is used a lot in echo. It hasn't been validated in MR, but there's no reason to think that it wouldn't be as effective. So it is measuring how the tricuspid annular plane moves between systole and diastole. So in summary, MR and CT can provide diagnosis, etiology, and prognosis. Pulmonary vessel diameters on CT can be used to identify the presence of pulmonary hypertension. There's no MR or CT method, for that fact, that directly measures systolic or mean pulmonary artery pressure. Best we can do is extrapolate. Ventricular mass index and septal shape are the best indicators of RV pressure, and a composite calculation provides the best correlation. Additionally, there are many imaging features of the right ventricle that are important in pulmonary hypertension that do not necessarily correlate with mean pulmonary artery pressure. Thank you.